I'm Lauren Meffin, speech pathologist and certified lymphedema therapist. We are going to take a look inside our patient's mouth today. So, after I treat a patient with head and neck cancer, and they are now in the survivorship stages, and they are coming for follow-up appointments, I want to do what I consider just an oral motor assessment and taking a look at the inside of their mouth. So, my patient is reporting difficulty with taste and a burning sensation on the tongue. First thing I'm going to do, grab my flashlight and look. I'm going to have my patient open their mouth and stick out their tongue. Now, I'm going to have my patient move their tongue from side to side. I'm going to have my patient lift their tongue up and point their tongue down. There I'm looking for range of motion. I'm looking to see, is the patient having any difficulty with deviations, one side of the tongue or the tip of the tongue going a different direction? Or is there any sensitivity or what we would consider hot spots or sore areas on the tongue? So as they stick their tongue out, another thing I'm going to do is have them stick their tongue out and say, ah, ah. When they do this, I'm looking inside their mouth at their palate, the hard palate. Hard palate is the roof of their mouth. Ah. Now, as the therapist, I may be inside there and kind of going all around what's happening. So, I want you to really encourage your patient. You're going to be in their personal space. Other areas that I check areas of sensitivity in the cheeks, on both sides. I tell my patient, I don't need your help. So, your patient is going to want to help you. You want to be able to see each of these areas before you go sticking your hands in their mouth. Now, I'm done taking a look at the inside of their mouth, their tongue, their lips, and just assessing jaw discomfort. I may ask my patient, is there any sensitivities or pain when you're opening the mouth? Sometimes patients after treatment will have pain or sensitivities in the regions of the joint, also known as the temporomandibular. If that is the case, I'm pausing, I'm assessing that and ensuring that that patient has what they need in those areas. Next, my patient says, my tongue is burning. I'm having difficulties and soreness when it comes time to eat. Now, I want to go ahead and check the inside of their mouth with my finger. I place a glove on. My patient has had radiation to the tongue, the lips, the jaw, and the regions of the oral cavity that control our saliva glands, the parotid, the sublingual, and the submandibular. They have what is called xerostomia or dry mouth. So I'm going to dip my gloved finger into a cup of water. I'm going to place that now so that I don't have a dry glove on a dry tongue, just around my patient. I'm going to let them know, is it okay if I stick my finger in your mouth? They say, of course, Lauren, yes. And then I'm going to just slowly start to feel. Now, every patient, depending on their type of treatment, will have different feelings in their mouth. If they've had surgery, you may feel incision lines. You may feel edema. You may feel swelling inside there. Next, after I've assessed the lips and the cheeks and the regions there, I'm going into the cheek. So I might need to take my slimy, goopy finger. And now I'm going to start at the roof. I go ahead and I tell my patient, I want you to open. I'm going to slide my finger in. Now, as the therapist, it's easier if after you have your finger in, you ask your patient to close their mouth. So I'm going to say, go ahead and open your mouth. I'm going to stick my finger in. I slowly reach my finger in, starting at the top. You never know where the sensitivities could be. Now I have my patient close their mouth. I can hear freely move around with my finger massaging from the top to the bottom, in the middle. I can also use my thumb on the outside as a resistance factor and see if there's any areas that cause any kind of knots or collections of fibrin or protein deposits. I want to establish what is my patient's new normal. So, I have also at this point clinically reviewed their scans, ensured that they are free of disease, and that I am understanding what's happening to their anatomy. Now, whatever I've done on one side of the mouth, I'm going to do on the other side, ensuring my patient is tolerating this and allowing me to move forward. I go ahead, dip my finger in. Once I get one finger slimy, I try to keep that one slimy the whole time. I go in, straight back. So once I go in, I'm pushing straight back, and then I feel all around on the inside. Now, I've assessed the gum lines, I've assessed the lips, I've assessed their cheeks, and I've learned what are some of their characteristics of the inside of the mouth. Now I'm going to go ahead and palpate their tongue. So remember, at this point, they likely want a sip of water if they haven't already taken one. And what I'm going to do next is I'm going to go ahead and dip my finger back in the water. When I encourage my patient to open their mouth, I'm going to have them ensure that their tongue is resting on the inside of their cheeks and on the inside of their teeth. Okay? So I don't want their tongue out like this. Why? Well, because I'm going to push down. I'm going to feel all around, and I don't want to dig their tongue into their teeth if they have lower teeth. So I'm going to have them open, and then I'm going to start to slowly touch the tips of their tongue. Their tongue is naturally going to want to fight me and move all around. And I'm going to slowly glide my finger back, trying my absolute best not to gag them and feeling all of the areas of the tongue. And then I'm going to come out. You can see my tongue wanted to help me. I don't need the help of my tongue. Now I've assessed their tongue, I've assessed their cheeks, their lips, I've looked at their palate. Sometimes, if I need to palpate the palate, I will. I'll go ahead, place this in, and touch their palate. Now, I'm done feeling around in my patient's mouth. At this point, I've palpated it, and I want to be able to describe the inside of my patient's oral cavity. It's very important from a clinical standpoint for me to describe the range of motion, the coordination, and the strength. I can identify those things also when I'm assessing what we call the oral stages of swallowing or chewing. But first, I'm just going to do a tissue assessment. So I may describe the lingual placement. Lingual is the tongue. Lingual range of motion is within normal limits, or lingual range of motion is reduced to the left. That could potentially be a possibility if I have a patient with a floor of mouth resection, or if I have a patient who is surgically altered from a glossectomy standpoint. I might say left lingual range of motion reduced, consistent with prior surgical history. That's it. Then I'm going to talk about and discuss observation of dried secretions and discuss where those are at, encourage the patient, whatever I have encouraged at that point. So maybe I'm having them take sips of water in between, improve their oral care. I'm addressing that. But these are all things that we can do when we work with the inside of a patient's mouth. So if you've never been inside a patient's mouth, I want you to start with your own. Start with your own, feel all around, get comfortable with those structures, get comfortable with the inside, get comfortable with a flashlight in somebody's personal space. And then once you're comfortable on yourself, find your favorite human, allow them to become comfortable. And then you can start to begin this on your patients. In the beginning, I was always very honest with my patients. I shared with them, I'm starting to navigate this territory, but I do have the support of a team to be able to help me. So, thank you for joining us as we talked through the tongue, the lips, the jaw, how to look inside, how to feel, and how to assess those structures. Join us as we continue down the head and neck anatomy.